Good afternoon, everyone. My name is Marimirofa. I'll be presenting on my abstract title, Knowledge, Attitudes, and Practices on Contraceptive Use Among Young People in Selected Universities in Zimbabwe. The study was conducted in 2019. There was a gap between high sexual activity and contraceptive use among students in tertiary institutions. Therefore, this gap is yet to be holistically determined across all institutions. There was also anecdotal evidence from researches by other civil society organizations in the country, which indicates that unwanted pregnancies and safe abortions and STIs have become major reproductive health concerns among students in tertiary institutions. Therefore, this study was conducted to assess the knowledge, attitude, and practices, as well as to understand the sexual behavior, knowledge, and use of contraceptives among young people in these selected universities in Zimbabwe. We also wanted to determine the health systems related challenges affecting access to and utilization of contraceptives among young people. The study was a cross-sectional using both quantitative and qualitative research approach. 4 universities were purposefully selected in the country, while key informant interviews, focus group discussions, and structured interviews were conducted. Desk reviews were conducted also on national documents to triangulate the results of this study with other national surveys conducted before. The median age of the respondents was found to be 21 years. 95% of the students were never married, while 33% of the students had spent less than a year at the institution, with 25% having spent more than 3 years at the institutions. Sexual experience was found to be increasing with age from 15.7% among the age group 18 to 19 years to 63% among the age group 20 to 24. The median age at first intercourse was found to be 20, with 8.8% of the respondents highlighting that they had first sexual intercourse at the age ranging between 12 to 17 years. Contraception use was also high among the age group 22 to 24 years, with those in the same age group ever used contraception. Only 7% in the age group 18 to 19% had used contraception before. There was also high use of emergent contraception in the age group 22 to 24, with 42% of the respondents highlighting that they had ever used emergent contraception. 35% of the respondents had used 2 to 3 times emergent contraception 6 months prior to the survey. 95% of the respondents highlighted that condom is a dual protection method for both pregnancy and STIs, including HIV and AIDS. Most female students also highlighted that they had a perception that men do discontinue condom use sometimes during sexual intercourse. 3% of the respondents highlighted that there were other traditional methods which were being used to prevent STIs and pregnancy. 66% of the respondents highlighted that they were using contraception for spacing and delaying having children. About knowledge on contraception, there was high knowledge across all institutions, with 100% of the respondents from Midland State University know about contraceptives. However, students highlighted that lecturers do not bother to teach about contraceptives, although some do teach during the orientation to new students on health and life skills. Students know most about the pill, with 85% of the respondents knowing about the pill, 82% know about the condom. The least methods known by the respondents were the permanent methods, tubal ligation and vasectomy. 13% also know about other traditional methods used as method of contraception. 68% of the respondents highlighted that they started to know about contraceptives during their secondary education. There was also an attitude towards those who were using contraception, the young unmarried young women in tertiary institutions. 67% of the respondents highlighted that those young women are very responsible, while 30% highlighted that those who are using contraception who are not yet married are very promiscuous. Orals, injectables, and condoms were the only methods highlighted by students that were found in health facilities within the institutions. Hence, there were no method mix or a choice for students. The type of condom also found within the institutions was not preferred by the students. Students were preferring to use emergent contraception, although they highlighted that it was not really available within the college clinics. There was also fear of parents, friends, and discrimination. These were major concerns of young women and men not using contraception. Students also highlighted that some contraceptives were being sold at exorbitant prices. However, this was outside the health facilities within the institutions. For those who were being provided with the health institutions, 50% of the students highlighted that it was very acceptable as they were being offered for free. Side effects, lack of knowledge, as well as religion were highlighted as some of the barriers to contraceptive use by young women and men in tertiary institutions. In conclusion, our study unearthed that increased awareness does not translate to increased uptake of services if the students are not well informed on the benefits of the family planning services. There is also need to motivate young people for effective and appropriate use of contraceptives as to arrest the upward trends in unplanned pregnancy and STIs and HIV. There is need to understand the challenges young people encounter which hinder them from accessing contraceptives. Thank you.
Thank you very much, Mercy. Excellent presentation. Now we're going to go into our second presentation, which is by Samukelisiwe Nyamathe from Hope, Cape Town, South Africa. Samukelisiwe is going to talk about risk of HIV infection in young peripartum women, that's aged 15 and 24, 15 to 24. And this is a study from Tygerberg Hospital in South Africa. Thank you.
Good afternoon, everybody. My name is Dr. Nyamathe, and I'll be presenting on a study that we conducted as an organization, Hope Cape Town, which looked at the risk of HIV infection in young peripartum women between the ages of 15 and 24 years old at Tygerberg Hospital. Okay, so the presentation outline is I'll look at the rationale for the study, the aims, the objectives, the study methodology, the results, some interesting findings, as well as future benefit and how we've gone forward from the study. Okay, so the rationale for us conducting the study is obviously we are facing a huge problem in South Africa in which adolescent girls and young women in the age group of 15 to 24 years old contribute a quarter of all new HIV infections in South Africa. As an organization, we normally look and deal with pediatric patients who are normally under the age of 18. But we've since started noticing that there's a huge problem in the adolescent age group. So 69,000 of new HIV infections in young women were in young women between the ages of 15 and 24 in 2017 to 2018. The HIV incidence in this age group is 3 times higher than their male counterparts. There's been great success with PMTCT in our country, and this is because a lot of women enter the healthcare services through PMTCT. However, we do now know that pregnant women are at a high risk of HIV infection, and this is probably because of the decreased condom use while women are pregnant. So we aim to use a validated risk score to determine what proportion of young women who give birth at Tygerberg Hospital could potentially be at risk for HIV infection. We aim to use the outcomes of the score and the interviews conducted with women to advocate for tailored interventions and to prevent HIV infection in this population. So the initial tool was developed from studies in 2016, which reviewed the VOICE, FemPrep, and HPTN 035 randomized control studies to develop a risk assessment tool with measured characteristics that predicted HIV infection in women in the year after risk assessment. The risk score identified 91% of incident infections in 64% of the women in the VOICE trial. So this tool looked at baseline characteristics which placed women at risk of HIV infection or were protective against HIV infection. And basically looked at the ages of the women who were either married, employed, the number of preceding births, alcohol use in the past 3 months, whether or not the partner had provided material or financial support, primary sex partners, as well as knowing the sex partner's other partners, whether their sex partner was circumcised, whether they had previously been treated for STI, and in the modified version of this risk assessment tool, the last 2 characteristics were excluded based on the fact that a lot of women did not know whether they had been treated for STIs or HSV2. So we did an observational cross-sectional study at Tygerberg Hospital in Cape Town. And the women who were included in the study were HIV uninfected women who are currently attending the antenatal clinic or admitted to the wards, the antenatal labor or postnatal ward. The team who did the recruitment process and who also helped with some of the interviews were Marimirofa and Alfreda Leroux. These were women who work in the wards and who are very familiar with the women who come in and out of the antenatal clinic and the postnatal wards. And they're often the team that provides a lot of the counseling and support to adolescent girls and young women. So what we found after interviewing 370 women between the ages of 15 and 24, that majority of the women were between the ages of 15 and 24. The mean age was 21, and the majority of the women had come from the city of Cape Town. Okay, so as previously mentioned, we did a primary risk score as well as a modified risk score, both of which showed significant high risk of HIV infection within the next year. In the first score, we saw that women had a 60% risk of developing HIV infection in the next year. And in the modified score, we saw that 57% of women had a high risk of becoming HIV infected in the next year. Through our interview process, what we also did was look at risk factors as well as protective factors against HIV based on similar studies which had been done in the past. What we found was that completion of secondary school, employment, marriage, as well as partner circumcision tend to be protective against HIV infection, even in this cohort. And the risk factors that we saw and that we found were things that we needed to look out for were women who had early sexual debut, women who had no idea of their HIV status prior to admission, and women who were involved in significant transactional and age-disparate relationships. Since then, what we had done was collaborate with other NGOs working with adolescents to develop peer support programs and to assist women to prevent the further HIV infection or infection with other diseases. We have also seen the benefit of adolescent clubs and have advocated for women in this age group to develop their own adolescent clubs for the future prevention of HIV infection in this cohort. I'd like to acknowledge the following people who contributed significantly to the study, as previously mentioned. Thank you.
Thank you very much, Samke. Our third and final presentation for today is by Carmen Logie from the University of Toronto, Canada, who will be presenting on contextual considerations to guide HIV prevention cascade optimization from urban refugee and displaced adolescents and youths in Kampala, Uganda.
I'm very excited to be here today to talk about our work with urban refugee youth. I want to acknowledge my co-authors, Dr. Moses Okumu, Robert Hakiza, Simon Mwima, Vibhuti Kacholia, and Dr. Peter Chimbade. There are 79.5 million forcibly displaced persons around the world, and 40% are under 18 years old. And we know people in humanitarian contexts experience increased exposure to sexual and gender-based violence, alongside unmet sexual and reproductive health needs. And we also know there are many barriers to accessing HIV prevention and testing in humanitarian contexts, but these are understudied among adolescents. They're also understudied among refugee youth who live in urban areas. Most of the research has been conducted in settlements. So we focused in Uganda. Uganda hosts 1.4 million refugees, and we focused on the 80,000 refugee and displaced people living in Kampala, the urban setting. A previous study we conducted, we found only 56% of refugee and displaced youth in Kampala had ever been tested for HIV, and we also found suboptimal STI testing. We found social ecological factors such as stigma and food insecurity were associated with both HIV and testing practices. So we actually applied Campbell and Cornish's conceptualization of health enabling social contexts, and we specifically looked at material contexts, which includes access to resources such as clinics, economic security, transportation, and symbolic components where people's dignity and value are respected and they're able to view themselves and others in a way that help them engage in healthcare. And so we conducted a qualitative study that involved 5 focus groups with refugee and displaced youth living in 5 of Kampala's informal settlements, in Zambia, Katwe, Rubaga, Kansanga, and Kablagala. 2 focus groups were with young women, one aged 16 to 19, one aged 20 to 24, and 2 with young men, same age breakdown. 1 focus group was 16 to 19, 1 with 20 to 24, and 1 with refugee youth sex workers. So we had a total of 44 participants. Most were from the Democratic Republic of Congo, followed by Rwanda, Burundi, and Sudan. And most identified as refugees, and 2/3 had ever received an HIV test, and over 3/4 were unemployed. So these are basically our findings in a snapshot. For material context, participants discussed transportation barriers, a lack of private spaces due to overcrowding and their living conditions, literacy challenges, and also language barriers. So because there's refugees from so many different places in Kampala, there's actually needs for translation in many different languages. We also found symbolic contexts were associated with HIV testing practices, including religion, medical mistrust, and inequitable gender norms. So for the sake of time, I'm only going to highlight a few examples. For example, in the material context, many people said because of the high rates of unemployment among refugee and displaced youth, they didn't have funding to travel to HIV clinics. And so on the bottom quotation, one woman is describing, even if there's a free service, if people have to travel to get there, they're not able to make it to that HIV testing site. We also were exploring HIV self-testing, and participants described that people are living in really, really crowded spaces. So it's hard to find even a private space to do the test. And there's also challenges accessing garbages that are private. So if you have a self-test kit that's used, where are you going to dispose of it where other people won't find the result? And literacy was an issue. And people said, even if you have illustrations, it might not be enough for people who've never accessed formal education. You might actually have to show people in person how to use, for example, an HIV self-test kit. For symbolic context, religion was an interesting finding because people talked about religion as a way that they stayed connected to their communities and countries of origin, so other refugees. And they also suggested that that's a great place to meet lots of youth if you want to engage youth, but you may have to do some work with religious leaders who might have prejudice. But we've also found this in other studies where you can engage religious leaders and have them be part of a solution for promoting sexual health. And others discussed there was mistrust of community-based outreach. So people who didn't know outreach workers coming in and offering testing. Some people, as in the first quotation, said, are they real people that are supposed to test? Are they trying to give us the virus? And others discussed widespread experiences across trajectories of coming as a refugee and being as a refugee of sexual and gender-based violence, embedded within inequitable sexual relationship power dynamics. And those really constrained women's ability to have sexual agency. So altogether, social environmental factors shaped engagement in HIV prevention and testing with urban refugee and displaced youth. We need to consider transportation costs, so beyond offering free testing, crowded living conditions, and the need to access private spaces, literacy and language. We also can really leverage the role that religion continues to play in refugee youth's lives by engaging with religious leaders. So we really need to think for developing health enabling environments. We do need to provide technical information, resources, and skills alongside addressing the social circumstances, cultural norms, and values that constrain people's agency over addressing their sexual health, while leveraging the strengths, resilience, and resources in refugee and displaced people's communities, especially those among refugee and displaced youth themselves. Thank you so much.